Force. Probably. Is there any event happened like in the stem? They haven't talked about any event. Okay. Okay. It's yes. So it's PTSD. Okay. PTSD clinical feature is exposure to life-threatening trauma, nightmare, flashback, intrusive memories, avoidance of reminders, dissociation, emotional detachment, negative mood, decrease interest in activities, sleep disturbance, hypervigilance, and irritability. Duration is more than 1 month. Treatment is trauma focused CBT and antidepressant SSRI and SNRI. These patients' sleep disturbance, impaired concentration, and persistent anxiety are most likely due to PTSD. His evidence of remainders of trauma, stopped working in the emergency department, self-blame, and negative belief about the world are also characteristics of the disorder. Other common PTSD symptoms include nightmare, flashbacks, irritability, emotional detachment, exaggerated startle response, and hypervigilance. First line treatment for PTSD includes trauma based CBT and antidepressant medication SSRI, such as paroxetine and SNRI, have the best evidence. Although anxiety and severe insomnia are common PTSD symptoms, benzodiazepine, lorazepam are not effective in PTSD. And benzodiazepine particularly should be avoided in patients with comorbid substance use disorder. Do you want me to read the other options? Okay. Although caffeinated beverage may exacerbate insomnia and anxiety, advising this patient to discontinue caffeine without addressing the underlying cause of his insomnia is insufficient. However, the patient could be advised to gradually taper caffeine use in conjunction with treatment for PTSD. Okay, option E, reassurance with close follow-up may be indicated for some patients with milder case of acute stress disorder, symptoms present less than 1 month. However, this patient has had persistent symptoms for at least 6 weeks that are causing significant distress and impairment. Early impairment of PTSD may prevent the development of chronic functional impairment. Next. Yes, it's ADHD. Yes. Okay, wait. Not truly ADHD, like school and yes, but uh, reassurance is not the option here also. Like it is not age appropriate behavior like hyperactivity. So so what? Okay, I am reading the explanation. I don't know. Okay, okay, it's parent management training. Okay, parent management training focus on antecedents, behavior, and consequence. Antecedents is communication leading to wanted or unwanted behavior. Use promote wanted behavior, clear instruction, calm tones, and supportive gesture and alternative choice. And avoid nagging, threats, harsh comments, and physical intimidation. Intimidation. Okay, behavior like practice effective parent-child interaction, shaping small behavior goals, adding to bigger changes. Role play wanted behavior, artificial situation first, build to realistic scenarios. I don't know what they are talking about. Okay, consequence. Okay, 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 okay. Consequence for okay. So hyperactivity and impulsivity. Being overly energetic, running off, taking toys, a non-specific feature may be due to ADHD or other causes like ineffective parenting, personality traits. When symptoms are frequent, cause impairment and present across multiple settings, school, home, physician's office. ADHD for which effective medication exists: norepinephrine reuptake inhibitor, atomoxetine stimulants, methylphenidate, alpha-2 adrenergic agonist, clonidine should be considered. However, when parents describe a child's disobedience as limited to home setting, problems specific to parent-children relationship should be suspected. In this situation, where the father has tried unsuccessfully to manage by using a self-help book, parent management training is the treatment of choice and provides an effective intervention for his daughter's inappropriate behavior. Parent management training helps parent identify effective parenting methods while redirecting them from ineffective methods. Session usually lasts 5 to 10 weeks and seek to identify antecedents, cause of a child's behavior and provide a forum of practicing effective behavioral intervention. Parents are also taught how to provide consistent consequence that promote wanted behaviors, targeted praise, point system, and decrease unwanted behavior through extinction and mild punishment. Okay, other option like option A, modifying the uh, patient's screen time. should be a part of overall management strategy because using it help her calm down and rewarding, which reinforces the unwanted behavior. However, the disobedience is not limited to screen time. Runs off at the grocery store, takes siblings' toys, so this alone is not expected to bring the long-term changes needed. Okay, option C, lead poisoning can cause behavioral and cognitive concern in children. However, these would be expected to cross multiple settings. Parent-specific disobedience and average grades suggestive ineffective parenting technique. Got it? Looks like this lady is suicidal, so admit the patient to hospital involuntary, even if she does not want to stay in the hospital. Okay, yes. Okay, in recent years, suicide has attempted with homicide as the second or third leading cause of death in adolescents. Between 5 to between 5 to 10% of adolescents make at least one suicide attempt in a given year. This patient has recently made a serious suicide attempt and is guarded and evasive when answering questions regarding whether she would attempt it again. She remains at high risk for another suicide attempt. She remains at high risk for another suicide attempt and should be hospitalized involuntarily even if is necessary for safety. Although efforts should be made to obtain parental consent, a minor can be involuntarily hospitalized for psychiatric causes without it. The exact procedure for involuntary psychiatric hospitalization vary from state to state. It is not possible in our country. Even if the even if physician wants to do that, he will be in jail. Okay, I have seen in the serials like uh what yes like Grey's Anatomy and this kind of serials. So on those serials, they have said that they try to admit the patient like involuntarily. But in reality, I don't know actually. Okay. Next, is she is in a thyroid status? Okay, that's maybe hydroxyzine. As far I remember, it's an antihistamine, first generation antihistamine, promethazine, hydroxyzine. Probably, may not be. I am telling wrong these days. Okay, she's. I am waiting for your answer. Okay, this is very confusing. If it happens in the exam, what we will do? We will lose our time just thinking about what's the answer. Okay, this patient anxiety, sleep disturbance, weight loss, tremor, sweating, and increased heart rate are consistent with hyperthyroidism. The first step in evaluating hyperthyroidism is measurement of TSH, which is low in infant, which is low in patients with hyperthyroidism. Many different disorders can cause hyperthyroidism, most commonly Graves' disease, and the diagnosis of the underlying etiology is unnecessary for appropriate treatment. Differentiating hyperthyroidism from anxiety disorder can be difficult due to overlap in symptoms, anxiety, insomnia, sweating, palpitation, some cases of hyperthyroidism and postpartum, some cases of hyperthyroidism and post that is postpartum and painless thyroiditis can present with minimal or no thyroid enlargement on examination, making it challenging to diagnose thyroid disorder. Signs and symptoms with thyroid dysfunction rather than anxiety disorder include unintentional unexplained weight loss, new onset atrial fibrillation, hypertension, lead lag, menstrual irregularity. To avoid misdiagnosis and inappropriate treatment, it is important to assess the thyroid function in patients with new onset anxiety, and associated physical symptoms. Okay. Antisocial personality, is it after 18? Yes, there is a time interval. Antisocial is after 18, as far I remember. And no, no, it's not substance induced. Why he is breaking the social norm now and then without taking the substance, and the substance and this type of substance taking people are plenty. Like, uh, sorry, like the adolescent or young people are very curious about newer substance, like they are very curious about the drugs like marijuana, like phencyclidine, these type of drugs. So they actually, some of them curiously take those drugs, not for addiction purpose. So uh, he is, I think that he is such kind of boy. But the temper problem, but the his psychological problem is inborn, like violating the social norms and the right of the others. This is his inborn thing. Okay. Okay, conduct disorder. Okay, conduct disorder, pattern of violating major societal norms or rights of others over the previous 12 months. Aggression and cruelty toward people and animals, destruction of property, setting fires, serious violation of rules, truancy, running away, and deceitfulness or or of theft, lying, stealing. CBT and the family therapy and parent management training. Okay, these patients, a persistent pattern of lying, truancy, stealing, and fighting is most consistent with conduct disorder. Conduct disorder is a childhood psychiatric disorder characterized by behaviors that violate the social norms appropriate to the age, excessive absenteeism, consistently staying out past curfew, or the rights of others, often initiating fights. Other behaviors seen in conduct disorder include bullying, using weapons, broken bottle, bat, gun, knife, torturing animals, setting fires. We have found a patient with setting fires, isn't it? That was the pyromania, like he loves the fire. Okay, setting fires, destroying property, and forcing others into the sexual activity. These contacts impact functioning, not graduating from high school. Conduct disorder generally presents in the middle of the childhood to adolescent and is more common in the boy. Adolescents with conduct disorder are at great risk for developing APD, antisocial personal disorder, as adults, and individuals must be age more than 18 to receive the diagnosis of the antisocial personality disorder and must have evidence of conduct disorder before age 15. So these two lines are very important. Okay, next. Yes. Okay, E and F. Okay, E is oppositional defiant disorder. Oppositional, ODD, oppositional defiant disorder is characterized by pattern of angry or irritable mood and argumentative or defiant behavior toward authority figures. Compared to conduct disorder, the symptoms of oppositional defiant disorder are less severe and do not include stealing or aggressive violation of the rights of others. These patients' history of repetitive fighting, stealing, and lying is more consistent with CD. Okay, oppositional defiant disorder is the pre-version of the CD. Is that their meaning? Like lower version of the CD. Like they have a pattern of anger or irritable mood, argumentative behavior toward the authority figures, but they do not break the social norm. Okay, okay. If sus- effects of substance use should always be considered in adolescent with behavior problem and mood disturbance. Although substance use might be related to stealing, irritability, and poor school performance, these patients' persistent pattern of violating major societal norm and the rights of others in multiple settings makes the CD more likely explanation for these behavior. Got it? Okay. This patient's recurrent nightmare. Mm, Where is the nightmare written? Okay, oh, monsters. Okay. So these patients' recurrent nightmares, violent themes in play, emotional reactivity with aggressive play, hitting, breaking, and social withdrawal after a traumatic loss of PTSD. Suggestive of PTSD exposure to trauma can occur through direct involvement in or witnessing of a traumatic event or by learning about violent trauma to the loved one. Young children with PTSD whose memories may not be fully consolidated often have nightmares. They are not specific to the traumatic event, monster being chased, as well as repetitive traumatic themes in play. They often struggle in emotional regulation, and may appear easily upset or angered with little provocation. They often struggle with emotional regulation and may appear easily upset or angered with little provocation. They most they may struggle with feelings of guilt, shame, or sadness. Other manifestations include dissociation, which may be mistaken for not paying attention, avoidance of place, people, or discussion related to traumatic incidents, Difficulty concentrating, decreased interest in play, and social withdrawal as seen in this patient. Okay. Okay, it's displacement. Psychological defense mechanisms are conscious. Psychological defense mechanisms are unconscious means of responding and adapting to different situations while preserving self-image. These mechanisms serve to decrease anxiety associated with shame and vulnerability and ensure a feeling of safety in the face of the disappointments. Immature defense, I am reading the explanation. Immature defense mechanisms are commonly seen. Immature defense mechanisms are commonly seen in children or in adults during times of stress. They provide short-term relief. They often result in long-term complications such as interpersonal difficulties and misunderstandings. Mature defense mechanisms represent a more constructive way to approach reality. Displacement is an immature mechanism that involves transferring emotions associated with an upsetting object or person to a safer alternate objects or person. This resident likely was shamed and angered by being reprimanded by the chief of the service. Instead of acknowledging her feelings, she displaces her anger onto a safer target by making shaming comments to the students she is teaching. Okay. Yes. So these patients' social interaction, fixed interests, this patient's social interaction, fixed interest, horses, difficulty adjusting to change and excessive sensory interest, repetitive touching of the blood pressure cuff are suggestive of autism spectrum disorder. In severe, in most severe cases of ASD, while language and intellectual development are affected, children are typically diagnosed at earlier age given the obvious deficits. However, there is a wide range of presentation in ASD. Patients without obvious early language, patients without obvious early language, cognitive and developmental impairment, often reported by such often reported by patients as being within the normal range, may come to clinical attention only later when social demands overwhelm the child's social economical limitation, moving from home school to a more socially demanding public school, and reveal impairment in functioning beyond those expected in peers of some age. Struggles with reciprocal interaction as conversations such as conversations preserve such as conversation perseverating on special or fixed interest. All she wants to do is walk about all she wants to do is talk about horses. Inappropriate mentioning about facts about animals and atypical eye contact often result in hard time in making friends at school. In addition, repetitive restricted repetitive patterns as a core feature of ASD often lead to an inflexible preference for consistent routines and predictable struggles during transitions or adjustment in daily schedule concerned with adjustment to new school. Patients also may have unusual reaction to sensory input, which can be demonstrated as either extreme aversion, refusing foods with particular texture, or excessive interest in sensory experiences, excessive touching or smelling of objects. Okay, now I'm reading the box. Autism spectrum disorder. Clinical features are deficits in social communication and interactions with onset in early development, sharing of emotions or interests, non-verbal communication, developing or and understanding relationship, restrictive repetitive patterns of behavior, repetitive movements or speech, insistence or sameness or routineness, intense fixated interest, and adverse response to sensory input may occur with or without language and intellectual impairment. Okay, next. Okay. These patients agitated and restless behavior, irritability, insomnia, and physical findings, sympathetic hyperactivity in the setting of protracted period of intense studying are most likely due to stimulant intoxication. Misuse of stimulants, especially prescription stimulant for ADHD, is relatively common, with amphetamine style stimulant representing the second most common second most common illicitly used class of drugs worldwide. A high risk group is students, in in these high school students preparing for final examination. Misuse is also particularly prevalent on college campuses when students value being able to remain awake and alert for extended study hours. Manifestation of sympathetic hyperactivity, hypertension, tachycardia, diaphoresis, hyperthermia, mydriasis. Psychiatric Psychiatric symptoms include anxiety, irritability, agitation, and in severe case paranoid psychosis, cardiac arrhythmia, movement disorder, and seizures can occur in overdose. In addition to supportive measures, benzodiazepine, lorazepam are considered first-line therapy to control psychomotor agitation and sympathetic hyperactivity caused by acute stimulant intoxication with methamphetamine intoxication. Benzodiazepine blunt CNS catecholamine release with improvement in blood pressure, heart rate, and hyperthermia. Okay. Yes. Yes. Option A, clonidine is alpha adrenergic agonist in the management of ADHD, opioid withdrawal, treatment resistance, hypertension. There is no convincing evidence of the benefit for the use of clonidine to treat stimulant intoxication. Although agitation, irritability, and insomnia may be seen in the manic phase of bipolar disorder, these patients prominent signs of sympathetic hyperactivity in the setting of staying up late to study makes stimulant intoxication more likely. In addition, the patient's age and short duration of symptoms do not support a diagnosis of mania. Lithium is first-line treatment for bipolar disorder but would not be effective in controlling acute agitation and sympathetic hyperactivity. Okay, option D, physostigmine is the antidote of the anticholinergic poisoning. Acute agitation, tachycardia, hypertension, hyperthermia may be present in both anticholinergic and stimulant toxicity. These may this patient has diaphoresis, not dry skin, and a mucous membrane, and lacks other classic anticholinergic signs, urinary retention, decreased bowel sounds. And the option E, beta blocker, propranolol are not recommended to treat stimulant toxicity. Got it? Okay, developmental milestones are skills achieved by 75% of the children at a given age and are assessed regularly at well child visits. At age 4, children are expected to able to catch a ball, gross motor, and draw a person with with three or more than three body parts. Many many also start to cut with scissors and draw a square. Typical language skills include speaking in small sentences that contain more than four words and can understand by a stranger. 4-year-olds should be able to name colors and answer straightforward questions and talk about something that happened in their day. So this patient's presentation concerning for language disorder, including his difficulty making himself understand in multiple setting, home and school, and use only two or three word phrases, and inability to name colors. Language disorders are characterized by a deficit in understanding or producing language and can present with limited vocabulary, inaccurate sentence structure, or difficulty using language to explain concepts or create a story. Children who have difficulty verbalizing their needs and being understood often express frustration in their ways, temper tantrum, or attempt to have their needs met through physical aggression, hitting, grabbing. Okay, okay, okay. Next, you want me to read the box? Oh, okay, I know this. That's why I haven't attempted. Okay, it's paranoid personality disorder. These patients first box pervasive pattern of distrust and suspicious beginning in early adulthood and occurring in a variety of settings, no clear delusions, believing beliefs being exploited or deceived by the others, interprets being comments and events as threats, reacts angrily, bears grudges, and questions loyalty of partner without justification. Uh, Differential diagnosis is delusional disorder, schizophrenia, schizotypal personality disorder. This patient's long-standing suspicion and mistrust of others, including medical professionals and potential partners, is characteristics of paranoid personality disorder. Although these patients do not have specific paranoid delusion, they generally mistrust others. They generally mistrust others' intention and typically believe that others want to exploit them. Doctors wanting to find something wrong so they can bill, others exploiting her small inheritance. Other characteristics include conver- oversensitivity to perceived criticism, reluctance to confide in others, and tendency towards aggression or defensiveness in response to perceived attacks. Patients' paranoid or belief patients' paranoid belief symptoms often result in social isolation, and strained interpersonal relationship. In the physician-patient relationship, these can manifest as the difficulty establishing rapport or creating a therapeutic alliance. Taking a non-defensive stance and carefully explaining things can be helpful. Okay. Okay. Protecting patients' confidentiality is a fundamental duty of physicians and prerequisite for developing a trusting physician patient physician relationship. This patient has explicitly requested the physician not speak with spouse. Responding to a demanding spouse is very challenging situation, but the physician is obliged to protect the patient's confidentiality and and to politely mm, decline the disclosure of any information, even if even this is upsetting the spouse. The only exception that justify breaching confidentiality are to prevent serious or imminent threat to the health and safety of the patient or others. These patients is not at risk for immediate suicide. He has expressed a wish to be a dead, passive suicidal ideation, but has no suicide plan or intent to harm himself. The presence of passive suicidal thoughts alone is sufficient basis for overriding confidentiality. Got it? Yes. This patient, like, why wife called you? Wife called you to know the information, like what if you tell her that your husband is in the hospital, then the wife will be suspicious, and his her, his wife will interrogate him to tell me why you go to the hospital, why you go to this. So that's why we are not breaching the confidentiality. And and the patient's wife did not show any sort of concern about the suicide, like he has suicidal tendency. Everybody in the world, when they are sad, they do not want to live in this world. This type of thought comes for anybody, but this is not the suicidal ideation, this is not the suicidal plan. If he, if if this patient's wife shows any sort of if this patient's wife tells any kind of history or any kind of information that makes you concerned, like he may going to have suicide, or he has the tendency of having suicidal ideation, so that time you can breach the what can I say, you can breach the confidentiality. It is not possible in our country too. If a patient wants, like if her wife came to you and asked the doctor is bound to say there is a problem. Okay. In our country, like there are some systematic problem, like no patient profile and nothing. Okay. Yes. Yes. It's hard, but for you to come to our country is most welcome. Multiforme, yes. Very, very aggressive tumor. 1 year, like 6 months to 1 year life expectancy. Okay. What will happen if he go there? Nothing works. There is no drug, or there is nothing. Like if you are, what can I say, if you try to help a people, don't try to help this kind of people, because this kind of people, if you put them on a clinical trial, this is that is very painful, that type of clinical trial. So for those type of patient, I think that palliative medicine is the must. Like make him uh, whatever the time he is living in this world, make him comfort or give him some comfort, because brain tumor is very pathetic. And headache, like whenever we have a headache for 15 30 or 1 hour, we know what is the meaning of the headache. uh, but uh, but if you want to help a patient like rheumatological disorder, like Frederick ataxia, this kind of, there are some trials and they actually work best, but not this type of, this type of aggressive tumor. If you put them on a trial, so they have to be in the hospital, they have to be in the always on the monitoring. They, so that is if somebody's life expectancy is 6 months, why you are putting them on the hospital for the rest of his life? I think that they should be, they should give comfort. That's why medicine came. That's my kind of thought. It may not, sorry. Yes. You can say that, because you will be wondered, like lots of people having cancer die in a very crude manner, because they are not aware of this palliative medicine. They do, they thought that they will gonna die and they start suffering. Why we are, is it is not right to make them suffer. I have the option, I have the power to comfort them, so why you are not doing that? Like if somebody has excessive pain, uh, you are not, if you are giving morphine them, so that is very helpful for them. But as, but in our country it is they are need specialized, like they are need a certificate for getting morphine, because this kind of drug is addictive drug. So that's why there is a concern, because patient may misuse this. Okay. And you will be I have seen a patient, you will be wondered, like how cruel we are, like people. Like I saw a patient who is diagnosed with like advanced renal cell carcinoma, and the oncologist give him a morphine to uh, comfort that patient, comfort the pain. Yes. Do you know what his family members does? That they actually buying the morphine, they actually buying the morphine, but they are not giving the morphine to that patient, because one of them, one of the family member is addicted and he is using that. But he is taking prescription made with the that prescription. So life is a very wonderful place. For me, it's a wonderful place. They 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 thought that as he is dying, why he need this medication? Okay. It, it's very hard. If I apply, I may not get the visa. That's hard. I need to make them confident that I will come back, and I need to submit plenty of paperwork. Like I am in, I am working in Bangladesh, like I am working as a physician, so I cannot stay there for long. So I need to send them plenty of paperworks along with the rotation paper, like rotation from the US. So plenty of paperwork need, and then they will decide that he will uh, they will give a visa or not. So it's a yes, still hard. They will not gonna give the visa. Okay. It's not schizophrenia or this spectrum, isn't it? Action. Okay. So he has some sort of psychosis, and he is on depression. But psychosis comes later. There is some sort of auditory hallucination also, like secret messages coming. Mm, it's for 1 year, so more than 6 months. Yes, he also has the features of the psychosis. I maybe it's schizophrenia. Okay, these patients delusions really receive special message from videos being secretly recorded. Negative symptoms, significant functional decline, and continuous impairment lasting more than 6 months are consistent with schizophrenia. Although common hallucinations are not required for diagnosis, these patients' negative symptoms include apathy, avulsion, affective flattening, lack of facial expression, alogia, very brief answer, and asociality. asociality, social withdrawal, and diminished interest in relationship. His course of illness is characterized by prodromal phase deterioration in academic functioning and progressive social withdrawal prior to the onset of the psychosis and prominent negative symptoms often which can be mistaken for depression. Our families who do not understand that negative symptoms are a core characteristic of schizophrenia may become frustrated with their family members and perceive them as lazy and unmotivated. Family intervention that includes education about the illness can help promote a supportive environment and improve outcomes. Okay, why not B? In major depressive disorder with psychotic feature is a severe subtype of major depressive disorder. The patient develops delusions and hallucinations, typically depressive themes of guilt, worthlessness. These patients' appetite, sleep, energy level are normal. Okay. And he does not have enough depressive symptoms to diagnose for major depressive disorder. Okay. Yes, we don't have methyl. Pupil is dilated in which drugs? Cocaine, amphetamine, tetracycline. These are the drugs causes dilated pupil. Fever, yes, yes. He is on benzodiazepine withdrawal. Yes, he has a history of benzos. May not. Opioid is suitable, I think so. Because opioid cause constricted people and opioid withdrawal causing dilated people. One thing, yes. and the withdrawal causing the abdominal problem like NVD, nausea, vomiting, diarrhea. Okay, okay, now, okay, the box. Alcohol withdrawal and alcohol withdrawal symptom: tremor, agitation, anxiety, delirium, psychosis, benzodiazepine withdrawal, again tremor, anxiety, and perceptual disturbance, psychosis, and insomnia. Benzodiazepine withdrawal cause insomnia. This is important. Opioid withdrawal: nausea, vomiting, abdominal cramp, diarrhea, muscle aches. Opioid withdrawal examination finding is dilated pupil, yawning, piloerection, lacrimation, hyperactive bowel sounds, and the stimulants cocaine and amphetamine increase appetite, hypersomnia, intense psychomotor retardation, and severe depression crash. There is no significant findings. So, cocaine cause increased appetite, hypersomnia, severe depression. Nicotine cause dysphoria, irritability, anxiety, and cannabis irritability, anxiety, depressed mood, insomnia, decreased appetite. Okay, these patients myalgia, nausea, vomiting, diarrhea, abdominal cramp, hyperactive bowel sound, diaphoresis, and pupillary dilatation on the second day of the hospitalization. On the second day of the hospitalization is most consistent with opioid withdrawal. Withdrawal may begin 6 to 12 hours after cessation of a short acting opioid and 24 to 48 hours after last dose of methadone. Other typical symptoms: irritability, yawning, piloerection, rhinorrhea, and lacrimation. Patients may have an elevated temperature but are usually afebrile, alert, and oriented. Although uncomfortable, opioid withdrawal is rarely medically dangerous. Treatment involves supportive care, medication, alpha 2 adrenergic agonist, methadone, and buprenorphine. Got it? Yes. The patient does not exhibit significant elevation in pulse and blood pressure or tremulousness, which would be more characteristics of alcohol or benzodiazepine withdrawal. Furthermore, these patients' myalgia, diarrhea, hyperactive bowel sound, and dilated pupil are strongly suggestive of opioid withdrawal. Option C: cocaine withdrawal is characterized by depression, fatigue, and vivid dreams, but typically has minimal physical signs and symptoms. Option D: lithium intoxication presence with coarse tremor, ataxia, altered mental status, nausea, vomiting, diarrhea. It is more likely to occur with lithium level above the therapeutic range, more than 1.2 milliequivalent per liter. And neuroleptic malignant syndrome is potentially life-threatening idiosyncratic reaction to dopamine antagonist antipsychotic, and typically presents with high fever more than 40 degrees Celsius and generalized muscle rigidity, autonomic instability, tachycardia, hypertension, mental status changes. And the option G: although this patient have hyperactive bowel sounds and dilated pupil, which can be seen in serotonin syndrome, he does not show other classic symptoms such as neuromuscular hyperactivity, hyperreflexia, tremor, myoclonus, hypertension, tachycardia, or hyperthermia. Opioid withdrawal is more likely. Next. Okay, inquire about the suicidal thoughts. This patient has this patient has several findings concerning for depression, including hopelessness, doubts that anything will improve, a low energy, weight gain. Patients with depression frequently have a somatic presentation, headache, neck, back pain, and may have difficulty describing their emotions. Further assessment of depression include a careful screen for suicidal ideation is the most appropriate next step in the patient's evaluation, particularly given for her multiple risk factor for suicide, chronic pain, recent job loss, self-medication with disturbance, isolation. Inquiring about suicidality allows for determination of appropriate and safe treatment setting. Hospitalization: if patient is actively suicidal, this patient should be asked if she has wished for death and has thought of killing herself. If the answer is yes, additional questions should be asked regarding methods, plans, and intent to act or plan. Got it? Okay, let's